Welcome to our second of two episodes on mental health from the St. Vincent de Paul Mission of Waterbury. We have this episode is called Suicide, a Public Health Crisis. First, I'd like to introduce the members of our panel. Dr. Charles Dike, who is the Medical Director at the Office of the Commissioner, the Connecticut Department of Mental Health and Addiction Services. Dr. Dike is Associate Professor of Psychiatry at the Yale School of Medicine.
Hi.
I'd like to introduce Holly Nichols, who is the Director of the Casa de Rosa Group Home from St. Vincent de Paul.
Thank you.
Dr. Cheryl Ellis, who is the Clinical Director of Western Connecticut Mental Health Services Waterbury site.
Yes, thank you.
And Mark Cavanaugh, Director of Quality and Client Services for St. Vincent de Paul Mission of Waterbury.
Thank you for having us.
Okay. Well, our topic today is suicide, and it has become very current with the recent deaths of some very well-known people. In June, the New York Times has put together a number of articles, including an article titled "How Suicide Has Quietly Morphed into a Public Health Crisis." What I'd like to do is first turn to Dr. Dike and Dr. Ellis about sort of what are the scope of this crisis, how is it compared to other causes of death or other public health circumstances?
You want to start, Dr. Alice?
Well, we look at the numbers and the data, and we find that 45,000 Americans killed themselves in 2016. And at that point, we begin to understand the magnitude of the concern and the issues. This is actually much more common than homicide. And unfortunately, I think a lot of people don't understand suicide. They don't understand the circumstances. And sometimes they don't understand the population that this likely affects. Men are less likely to seek help. They struggle internally and oftentimes will act out on that distress and frustration. They're also more often to use lethal methods and may not say anything. You may not know, and there's signs and symptoms that we should be looking for. So let Dr. Dike speak a little bit.
I'm going to jump in for a second. Now, Dr. Ellis, now I had always heard the number was 30,000 deaths per year from suicide, and what's reported now is it's 45,000 deaths per year.
Yes.
That's a huge increase.
Yes.
Yes, well, as Dr. Alice was saying, I just want to highlight and emphasize again that this is a public health crisis. Suicide is now the 10th leading cause of death in the US. And many more people, double the number of people, die from suicide than die from homicide. So the mass shootings raise a lot of media hype and media scrutiny and a lot of discussions. But no one is talking about suicide. It's silent. Even though the number of people who die from suicide are double the number of people who die from homicide. So this is a real struggle. I mean, if in 2016, 120-something people die every day from suicide, we're talking about a real crisis here. And, you know, we can go into some of the reasons why this might be happening at this time, and why do people, why is it, or how can we be paying attention to this?
Okay.
We can talk about that a little bit. And if I may just say a little bit about, I think most people who have or who die from suicide, the majority of them actually have underlying mental health difficulties.
Okay.
And so that one has to underscore that as well, that as a result of either untreated mental illness or not inadequately treated mental illness or lack of access to mental health services, people are either not being identified early enough or treated adequately enough to avoid these high numbers of people who ultimately kill themselves. It's a real serious issue.
Dr. Dickey, I wanted to back it up just a moment.
Yes.
So you're saying that suicide is now the 10th leading cause of death in the United States. So
That's
that's behind things like heart disease, cancer, things that we traditionally have known. But that's up in the category of those diseases and causes of death.
That's correct. Now, one of the struggles I also have thinking about this is how much of these numbers, these new increases in numbers we are talking about today, are actually new. Because people don't talk about these things.
Okay.
The one thing that's happening these days is at least when the people who are well known commit suicide, a few more people would then identify themselves as having depression or having suicidal thoughts. So are people talking about it a little bit more now and therefore the numbers seem high? Or have the numbers actually gone up more? My sense is both of them.
Both of those things may be true.
They are, both of those things are operational.
And now, in my background, I was always coached that sometimes if a newspaper report said died suddenly at home, that was often a suicide.
That's what I meant by people would not disclose
It was
what the
not
cause of
noted
death
as
was.
suicide. Okay.
And sometimes people indicate overdose, and they don't necessarily see that as a possible suicide as well.
Okay.
That's correct.
So the idea that this is a public health crisis, its numbers are strikingly high, even compared to homicide and other medical causes. The idea that this has become a topic that now gets some attention with the number of veterans of foreign wars, Afghanistan and so on, that have committed suicide. That's getting some attention now. But the larger number is, as you say, Doctor, has not gotten the attention that other public health issues might have gotten.
It's very disheartening because there is so much around heart disease and HIV and whatnot, and the recognition with that is so high, and here we are in a public crisis over suicide, and there's like really nothing out there. It's very disheartening, and it's, where do people go? What do people do? You know, we shouldn't be afraid to ask people. We shouldn't be able to talk to people about, you know, are they concerned? Are you feeling sad? We should be able to maybe give them ideas on where to go, therapy sessions. I mean, I know Mark over at Cornerstone, you guys do some stuff like that.
Absolutely. I mean, I've actually met a few suicide survivors in my lifetime, and one gentleman survives his jump from the Golden Gate Bridge, and he had supports in his life. He had a strong family. And when he reached the point where he made his decision that he wanted to try and end his life, and he got on the bus to ride to the Golden Gate Bridge, and he handed the bus driver the money. And as he walked by people were asking him to take their pictures. And all he said was he needed one person to say, "Hey man, are you okay?" Mm-hmm. And that's often all it takes. And Holly's right, we need to not be afraid, if we're concerned about somebody, to reach out and ask if they're okay, because it may save a life.
So now, I think there's a general idea that I shouldn't bring their topic up because maybe I'll give them an idea. That I shouldn't say, ask somebody if they are thinking of ending their life or harming themselves because maybe they don't, that would make them think of it? Is that?
I think we need to be able to talk freely and openly to help people see it as a treatable medical, we can help them, we can treat them.
And I think the research has shown that when you ask the question, are you okay, you don't seem yourself, it gives people a door to be able to start the conversation and get the support and, you know, some direction. So we do need to talk about it.
One of the things I'd like to add to this conversation is, what are the conditions that make it likely for people to commit suicide? And I think, for me, one of the really interesting things is people believe that with the presence and multiplication of social media, that people are really well connected to each other. Whereas in fact, people are less connected with each other. because people are more isolated in their small basements playing one kind of game or the other. And then, people, when you watch them on Facebook, they post these pictures of themselves smiling, doing all kinds of activities, and you think, oh yeah, they're having fun. But they are alone in a corner, in a dark room by themselves, posting these pictures, completely isolated. So even the social support network that used to hold people up, that used to say, hey man, how are you doing today, as you said, there's no one to do that because they're all isolated. Mm-hmm. That's one big issue. The other issue is when someone now decides that they want to do it, and the next thing is they have ready access to lethal weapons. And everyone knows that ready access to lethal weapons is actually more dangerous for suicide than for homicide. And it's because there's really no coming back once you do that. You're struggling with depression, you begin to have suicide thoughts, you're thinking, yes, oh my God, I feel worthless, I feel useless, and I'm a burden to everybody else. I'm better off dead so everyone else can have a good life. And once you begin to think that way and you have access to a lethal weapon, it's very difficult.
So Dr. DK, you raise two separate issues. One is some of the traditional cultural supports of being involved with people, being connected, having teams, having more engagement with others is protective.
That's correct.
Of suicide, of depression and suicide. The other idea that you put forward is that if a person has the impulse to harm themselves, lethal weapons are no way to come back. That somebody, if you have access to firearms, for instance, I understand that, Mark, you were telling me that states with...
Yeah, the states that have the strictest gun laws have the lowest suicide rates. So that's clear data that the access to the weapon gives people more opportunity to complete that task, and it's dangerous.
Okay. So risk factors include, as Dr. DK has said, the depression, feeling worthless, feeling like other people would be better off without me.
Yeah.
Access to lethal means such as firearms, because it's not a casual thing.
There's no coming back.
To use a firearm.
An overdose can sometimes be reversed. Yeah. You might be able to survive a jump from a bridge, but there's no coming back.
But firearms are one example. It's not all firearms.
Not all firearms.
And I know that Texas has very open firearms, and they have a relatively low, a very average suicide. But the states that are good are places like Connecticut, Massachusetts, New York, where there are more strict rules.
That's right.
About firearms.
You want to add some more risk factors to that?
Certainly.
Well, I'm also thinking, and a lot of people don't think about the LGBTQ population, where there's a sense of shame sometimes when people can't be who they want to be or who they are. And a lot of times they're kind of in isolation, as Dr. DK mentioned, where they feel there's no one to talk to, there's nowhere to go. And again, that shame, that guilt, that feeling of being alone in whatever they're struggling with also is a risk factor in suicidal ideations and thoughts.
So, and is that particularly with younger people, or is that within the LGBTQ community? Is that all across the whole community, or particularly with the younger members?
The data right now says it's younger children,
people.
oftentimes 12 and early teenage years into late teenage years.
Are greater risk factors.
Yes.
Okay. We mentioned depression, where a person whose thoughts in depression often revolve around feeling hopeless, feeling worthless, feeling as though there's no future and that they're a burden on others. What's practical help? How do you talk to somebody who is depressed? How do you make that connection? So Dr. Ellis, or one of you has said that bringing it up doesn't mean you're going to hurt a person. Mark said that bringing it up can actually relieve a person. Bringing the question up. How do you help somebody? How do you talk to somebody?
I think the first thing you need to first try and understand if somebody's behavior has changed. You also want to try and think, what are the things that are likely to make an individual begin to feel really depressed and suicidal? So sometimes it's chronic, unremitting, difficult, painful medical conditions.
Okay.
Sometimes it's a loss of a loved one, especially if you're elderly. Sometimes it's divorce. Sometimes it's financial stress. Sometimes it's sudden use of these dangerous substances these days. All of these things increase the likelihood that someone might begin to feel down and ultimately begin to feel depressed. So I would say once you identify that these things are going on with an individual, that's your first warning sign.
So the first warning signs are changes in a person's life that may affect the way they behave, what their activities are in living, how well they have managed to maintain themselves. For example, a person who's had losses or deaths, what happens to them? A person who's in grief, for instance.
So that's where what you were saying about engagement, about the society, putting their arms around the individual who's going through a loss or who's having financial devastation or any kind of major stressor like that. When you talk about LGBT, you're talking abuse, and I think a lot of it could be through the internet or out. But just being there to support them and ask, how are you doing? And finding out what their moods are like, trying to get a sense whether they're hopeless, whether they're helpless, or what you said, worthless. Are they beginning to think that, they're better off, not being here? Are you thinking that maybe you would like to go to sleep and not wake up?
Wake up, right.
And so you start slowly to get into that kind of conversation before you actually get into, well, have you actually thought about some things that you might do to take your life?
And sometimes people will make statements like, I feel trapped. I just don't belong here anymore. And those are also signs. They're not making a direct statement, but they're giving you little hints, innuendos that something's not right with how they're feeling.
And I think what's important too is recognizing the power of just showing up and being there.
Yeah.
And it's not necessarily about trying to cheer someone up. It's about validating what they're experiencing and recognizing what they're going through is real and that you're there for them however they may need you.
Right.
So validating, let me help understand what you mean by that.
I understand that what you're going through is really tough right now. It must be really difficult. Is there anything I could do to help?
So not trying to cheer me up. If I'm the person that Dr. DK said has had losses or frustrations or cause to become depressed, telling me to cheer up isn't helpful.
No, you really have to try to understand what the person is going through and say, it's got to be really hard, and we're in your corner for you here. Trying to distract you with jokes and cheering you up may not be the difference maker. It's really about validating what you're experiencing. And
Okay.
More than that, it might deflect from you. I'm sorry.
No, it's okay.
Just one. Let me just add that. More than that, it might deflect from you. You might begin to think, oh, they're well, because you're trying to cheer them, you're giving them a joke, and they're smiling at the
Right.
joke. You might have a false sense of
That's right.
security that they are well when in fact they are not. I'm sorry.
No, I was going into that too. And listening is a big key.
Not being afraid of the topic, I think, matters, because if I speak to somebody and they appear to cheer up, and I say, good, now I'm off the hook, as opposed to being, because I don't want to think about it. But it sounds like when we say it's a public health crisis.
It really is.
Well, I think commonly people often say, I didn't know they felt like that. And sometimes just noticing a slight change and being able to be present and say to the person, I noticed you're not yourself, can open the door. And I think sometimes we even miss those small things.
Well, I think it brings it back to what Dr. DK was saying about social media. How do you not, if you're on your computer in your basement, like he said, playing a game or something, you're not face to face with someone, you're not having an actual conversation with them. Between texting now, I mean, people don't even call on the phone anymore. It's all through text or, send a picture or
So
this.
you can't even hear the voice to know
Right.
that something's changed.
Yeah, how do you, yes.
So if a person, in practical terms, so talking about suicide, asking about it is not going to make it happen. Is not going to give the new idea to a person. So that's not true.
In fact, when I was in training, people emphasize that a whole lot, because even today, if you talk to people, family members will say, Doctor, you put that idea into his mind.
head.
Right.
Yeah.
How dare you put the idea into their heads? whereas in fact they're struggling with it already. And by you saying it allows them to overcome the stigma and the shame of talking about being suicidal, which is huge. So you've opened the door to actually allow them to be able to talk about it finally, and hopefully be able to seek help.
One of the pieces I've worked in hospitals for many years is this woman I spoke to said that in an emergency department, I guess it's the shame that Holly had mentioned, there's guilt and feeling bad about it, it's a topic we don't speak about. She said no to the first person, she said no to the nurse, she said no to the first psychiatrist, she said no, she said no. People kept asking her and she finally said yes. Yes, I feel like killing myself. So that it's not, I'll take the first answer, it's really being there because it's such a shameful experience that people encounter. I know that Dr. Ellis has a package of suicide warnings that we'll have up as a posting in the course of the talk today. What does a person do when they have a concern that their friend or family member is suicidal or has fear that there's a risk for them right now? Mark said you have to show up.
You have to show up. I mean, you have to be there for your loved one or your friend. But really, there's suicide prevention lines to reach out to, and really trying to get the help that's out there in the community, and getting to that first appointment, to really talk with a professional to work through your depression and your suicidal thoughts. And even through, the job's not over of your support of your friend or family member once they're in an appointment. It takes patience and time, and it's a lifetime of recovery to overcome that, and being there for that is the most important thing you could do, really.
So being there for the person is important. Now, what if not all professionals are the same? So if you ended up with a professional, they said, well, she and I or he and I didn't really set it off well. What happens then?
I say you usually go with your gut, and that person may not be a good match for you, and you seek out someone who may be a better match for you.
So it's okay that if a person seeks someone,
yes.
if you just say, I just don't care for him or I don't care for her, to go to another different person is okay.
The more you're comfortable the more you're willing to open up and share things and talk. If you're not comfortable and you don't meet with someone,
You're not likely to trust and develop where you could even say what you're feeling if you don't feel good with the person.
Okay. So finding a person, a counselor, a therapist, a physician to speak to that works for you is important. And I heard one of you say that about research that treatment makes a difference, treatment works. Is there any comment on that?
Yeah, so treatment definitely works. We have spent today talking mostly about depression, but I want to talk a little bit about accidental overdoses that also lead to suicide. You know, people are not intending to kill themselves, but you're using these dangerous substances. These days, you know, with the new and impure substances and illicit drugs, lots of people are dying from accidental overdose. So a discussion about suicide also has to include things like opioids, things like alcohol. In fact, this is still a huge cause of death, and you know, like Xanax and people use a lot of Valiums, and all those things can cause death. But treatment definitely works. It's now clear. There's no doubt anymore that treatment works for psychiatric disorders, and the treatment is not just medication, which works significantly, but also social interactions, psychological, which is the talk therapy, social and spiritual, and all of those areas together help an individual move from an area of despondency and you know, no hope to an area of hope. So social support networks, having a job, having housing, having, you know, a connection to their, whether it's Islam or church or to their rabbi, and also taking medications. They're absolutely crucial in combination.
So medications for depression and anxiety are very helpful.
Very effective too.
And effective.
Yes.
Talk therapy, counseling makes a difference.
Very
so
effective.
It's not one or the other, but the two together
That's correct.
make the most difference.
That's correct.
And you mentioned like substances, so that one of the other items that I had seen is that a very high proportion, like 70% of people that have died of suicide or self-inflicted injury have had drugs, alcohol in their system at the time.
That is correct. So we people sometimes, in trying to commit suicide, we talked about access to lethal weapons, but the idea of taking your life is a really serious issue. Sometimes people would need something to distract them, to disinhibit them, and so they use substances.
Right.
So the impulse is worse in the event that a person is using drugs or alcohol.
That's
Yes.
correct.
And your chances of acting upon an impulse are worse.
The control is gone.
The control to
Right.
prevent your impulses.
Yes.
And one of the warning signs is actually an increased use in substances, so people may start using more.
So that's a greater risk factor.
Yes.
The more people using. Well, we are nearly at the end of our time. I think we had a very important discussion, and as Holly had pointed out, that when we spend as much attention on heart disease and HIV, the numbers came down. But the numbers for suicide are not coming down, they're going up.
Right.
I would like to just give a moment of how you can help St. Vincent de Paul Mission of Waterbury. Go to the St. Vincent de Paul Mission of Waterbury website to support the organization. Please like us on social media so that you can get updates and information of what's happening. Individuals or organizations can sponsor donation drives. The mission has lists of items that are needed, such as bus passes, gift cards, and clothing. Individuals or organizations can volunteer at the different areas of the St. Vincent's mission. Skills with facilities like painting, or personal quality of life skills such as literacy, art, yoga can make a difference. I want to thank our panelists, Dr. Charles
Thank
DK,
you very
Medical
much for
Director for the
inviting us.
Department of Mental Health and Addiction Services, Holly Nichols, the Director of Casa de Rosa
Thank
Group
you.
Home, Dr. Shell Ellis, who is the Clinical Director for the Waterbury Office and Region, Mark
Thank you.
Kavanaugh, who is Director of Quality and Client Services for St. Vincent de Paul, and I'm David Howe, the Clinical Director for the St. Vincent de Paul Mission of Waterbury. Thank you.
Thank you very much.
Thank you.